So here to discuss those dynamics in 60 minutes or less, Brad Burkett will lead a discussion between a hospital system CTO, a consultant who specializes in IT strategy for hospitals, two of them in fact, and the CIO of Walgreens. Brad.
Thank you, Brandon. Good morning, everybody. I think we're going to start just introducing ourselves for a minute and then jump right into the panel. Thanks, everybody, for coming out on a dreary morning, but I hope we get everything kicked off in a provocative manner, as we've talked about on our panel. So I'm Brad Burkett, co-founder and senior managing director of Matchpoint Partners. You may have known us under our previous name, Epsilon Securities, and we're in the process of rebranding to Matchpoint because we focus on companies, technology and healthcare companies, really with less than 20 million in revenues, and help the companies through strategic and M&A transactions and fundraising. So we call ourselves a consultative merchant bank, which is a little bit different model than a traditional strategic firm. It's a little bit different model than an investment bank, but we work specifically with a lot of the companies here today. So pleased to be with a panel of true experts in the provider space, and like to ask you each just to take a moment to introduce yourself and your background. And Tim in the leadoff chair.
Sure. Good morning, everyone. Is this on? Yeah, okay. Good morning. I'm the CIO for Walgreens. I have 25 years of financial services. So Brandon talks a little bit about, how the industry is evolving, the way a prescription could be done on a Post-it note. From financial services, I see a lot of things that we're able to do about sending money to each other electronically and how easy and simple and how the industry has come together. And working in the healthcare industry, you can see that it's much more fragmented. And our hope at Walgreens is to think about how we can bring more connectivity across the country to all the different regional players and so forth. The title of the program, Lower Cost, Higher Quality Care, is something that we're ambitiously trying to pursue and believe technology could play a very important part of the consumer experience around healthcare. The healthcare system has predominantly been known as a caregiver-centric. We think that we could become consumer or patient-centric around some of the services and offering and help people improve access, but at the same time, lower cost over time. So it's a pleasure to be with you this morning. I look forward to being part of the panel.
Thanks. Al?
Yes, good morning, everybody. My name is Al Campanella. I'm the Chief Information Officer at Virtua Health. We're a 4-hospital integrated delivery network in southern New Jersey, and we serve the 3 counties east of Philadelphia. So this is a very exciting time to be in healthcare. I think we're seeing a convergence, really, of market forces, political forces, the drive of technology, and also greater consumer abilities to engage. And so as a provider, we're trying to help lead that effort in our community. At the end of the day, we want to make sure that our community is really served. That's our mission. That's what we're trusted with. We've been around for 120 years, and we want to keep on serving that community.
Kaveh?
Great. Good morning, Kaveh Safavi. I'm a North American Managing Director for Health at Accenture, and among other things, one of my responsibilities is internal direction around strategy, growth, and investment of our own assets, which would include everything from methodologies to software. Just a word about the perspective that I'll bring today. Accenture primarily serves large organizations that are trying to improve business process and change. So that's the bias that we have. And we focus on 3 different aspects, what we call the design aspect, which is the typical kind of consulting, the build aspect, which has a heavy dose of information technology in it, and then the run aspect of it. And one of the interesting things that health is going through right now is this realization that change has to occur at large scale, not small scale. 20% change, not 2% change. And that requires, in many cases, a different perspective than what had historically been brought to the table. We'll talk about information technology, but one of the other things that's also going on now is health is an intensely labor-intensive activity, and so the idea of how do you change the dynamics of labor, whether that is using technology to get better productivity, using technology to replace labor, either directly or through self-service, and now we're even beginning to see a globalization of the labor workforce, something that hadn't been historically seen in health. For example, we now have over 1,000 licensed nurses in Manila providing services that licensed nurses in the U.S. historically had provided in certain parts of healthcare. That's never been done. That hasn't been a typical strategy in health, but you're beginning to see even those kinds of things occurring.
Great, thanks. John?
Great, John Kontor. I'm an internal medicine physician, but started my career as a software developer, actually building video games. And as I was putting my CV together for the conference today, I was talking to my youngest daughter, and she didn't realize this, and she said, "Dad, you used to make video games? Why'd you have to become a doctor?" But I think that's actually informative, because you get this feeling in the healthcare space now that much of what we do is about technology and analytics. But I think what I do a lot of with Clinovations, Clinovations is a mid-sized health management consulting firm with sort of an addiction to health IT, is help bring the various solutions that we have to reality. And in some of my comments today, I think you'll hear me focus on taking the promise that the space is putting out there now and trying to make it practical and beneficial today, which I think is one of our biggest challenges.
Great. Thank you, gentlemen. So, the title of our presentation here is Lower Costs, Higher Quality of Care. And obviously that's been something that healthcare has been searching for as long as I've been in healthcare, which is approaching 20 years now. But finally, we seem to have the technology capabilities to get there. Brandon said, remember the health days, and you can be early and you can be wrong, and maybe they're both the same. I was lucky or unlucky enough to have run an EMR company back in 1999, and it was a FedEx tablet, and we had guys crawl around the ceiling and put repeaters in every 6 feet, and once 2 doctors tried to send a message, it crashed. So we've certainly advanced a long way in what the technology can handle, but now what's interesting to me is, if you would have told me 10 years ago you'd have a panel called providers, and it's a mix of Walgreens, and it's a mix of a hospital system, and it's a mix of different sorts of consulting folks at Clinovations and Accenture, and very different guys now all on the same side, maybe, trying to get to lower cost, higher quality, and do it quickly. The government's mandated that a lot of these changes have to happen. Who knows whether that's going to occur or not? We're not going to debate that today, thankfully. But what are we going to do? I mean, so we've tried denying care outright. That doesn't work overtly anyway. The whole move to limit provider choice didn't really work. So now we're running a technology. So this new technology that's out there, and Jonathan, at the end of the day, I'm sure will tell us how the physicians are being helped, but now we have technology that can collect the information for care coordination. It can collect information for better billing and collections. All this information now is going to enable better and new payment models. People will be able to take risk if that's something people want to do. I've lived through a couple of risk cycles, as many of you probably have. It's pretty hard to take risk, but now maybe with this data we can do it. The other piece of technology is better patient engagement. So what does that mean? And I think on the panel you're going to hear a lot of different views about what patient engagement means and how to get there. Is it rewards? Is it gaming? Is it emails? What is it? So we have the EMRs in place, thankfully a lot better than the one I had 10 years ago. The EMRs are collecting the data. The health information exchanges are starting to move data around inside the walls, outside the walls. But we still need to harness all this. So what I'd like the panel to talk about today, as convergence is happening, as we're moving towards 2013 and 2014, what parts of the solutions do you see lacking in the marketplace, but what parts of the solutions are working? Is interoperability really all that it's cracked up to be? So again, we have a very diverse group here, which we're lucky to have. And I'd love to kick off with Al, as the CIO of Virtua, which is a traditional provider, hospital system, center of the universe, maybe staying in the center. Can you talk about how you're using IT to connect your system inside the walls and outside the walls, and what your challenges and benefits have been from that?
Sure, I'd be glad to. Well, over the last 5-6 years, we've really done a full makeover of our IT portfolio. So we started, back 5-6 years ago, redoing our entire network, big fiber optic network. We're actually in 80 buildings in 3 counties. So 40 of those buildings are physician offices, and the other 40 are hospitals and support buildings. Then we also addressed all the actual application portfolio. So there we did all the traditional things you do in our world, where each business unit has the right IT tools for that, and the big one being, of course, these things called EMRs. And so we're well, almost finished all of that. And then in very recent years, we've started to build really an interoperability layer on top. So we just went live about 2 weeks ago with our HIE platform. We, about 2 years ago, went out with the Microsoft Mayo PHR, Personal Health Record, and then we plan on adding on some more features to that in the very short order. Since we are so dominant in the market, we took on that HIE piece ourselves, as opposed to doing it in a consortium type way, and now we're inviting others to join into that. So there's a lot there. I think, though, that the IT, let me just start off by saying IT is always an enabler, and I think what's driving a lot of change, as much as it is that technology is there, and what problem is it looking for sometimes, it's really the economics, I think, are still driving change more than really technology. And I think what we're seeing in the political arena, what we're seeing by big employers, that's the demand side of the equation. It's saying we want to pay less, we want you to be more efficient. Why don't you think about other reimbursement models? That's what we look for first, is, are we going to get paid? And then we say, okay, well, how can we supply, on the supply side of the equation, how can we supply those services in a way that's efficient, provides quality, and also meets the demand of the customer, which could be a large payer, it's the federal government, and so forth. So I think as much as we want to talk about technology as being, the hammer that's going to hit the right size nail, follow the money. What are we doing? What's the larger economic situation?
Thanks, Al. Tim, as CIO of Walgreens, I think you have a very interesting perspective on where Walgreens is moving in what I'm calling the healthcare ecosystem. Can you share that as well as how you're using technology?
Yeah, be happy to. We have 8,000 locations across the United States, and we have 6 million people coming to our stores on a day. 1 million people a day hit our website, including drugstore.com, and also 2.7 million people into our call centers. So we have about 10 million points of interaction on a daily basis, predominantly, mostly around healthcare. And with our convenient locations, we are building a lot of new technology, which we call Walgreens Health Cloud. And the purpose of that is to put an EMR in every location. So it'll be widely deployed EMR, 8,000 locations. Our mantra is, like the convenience of our stores, is you don't have to be patient to be a patient. So the idea is that people can conveniently make their appointments on soon to come to the mobile device. We'll have a program where we identify the patient, so when they make an appointment, the ease and convenience of the clipboard being available electronically and for them to update that information. So when they come in to the clinic or to the pharmacist, being a chronic condition, everything will be up to date and known. And then the service interaction will take place. And if it's an acute episode and they need a prescription, they'll get the prescription and get out. And then after the visit, we will provide them with the right information online through patient portals, through mobile and web devices, and with the idea that we will link that information to their primary care and to other interested parties, maybe a family member or something. So those are the things we're building and aspire to build. Right now, you see a lot of consumerization of healthcare. I think you see a lot of consumerization of technology. And retail is by nature consumerization. So we believe we're in a good position to be able to provide access to people. And with the shortage of primary care doctors emerging, someone's going to have to fill that void. And we believe the pharmacist is well-trained to do a lot of things and can step up and to provide more consultation and support through patients throughout the country across a common platform.
Okay. Great. Thank you. Kaveh, now, your client base is across many different pockets of provider the provider landscape. Can you talk about what you're doing in terms of ROI? Al mentioned the solutions he's looking for have to deliver ROI, and I know that you need to help your clients find that.
The return on investment question has always been an interesting one because there's really the returns are both economic and non-economic, and the traditional metrics that we use, at least first order, have always been economic. I think that we can't describe it, we can't use the monolithic term technologies, but when you look at technologies designed primarily to improve clinical effectiveness, that's historically been driven largely by non-economic returns, essentially transparency, regulatory framework, et cetera, because the markets, it's been hard to recognize a very directly, easily measurable economic value. On the other hand, those technologies that focus on patient experience or otherwise improve operating performance have generally either lived or failed because they do, in fact, create some kind of measurable economic benefit. I think that technology is way ahead of, as Al said, the business in terms of both a business model, but also we're still at this basic challenge where we can't decide whether or not holding information, the best way to compete is to hold information or to liberate information and then build upon it and create something more superior. And that debate still continues to go on, and until we get more consistent demonstrated experiences that you're better off letting the information go and then doing something positive with it rather than simply controlling it, we're going to have a challenge. Now, that is a little bit the ethos of medicine, right? Was essentially creating artificial scarcity by holding things back in order to create value. So we are struggling with our mindset that the path to value isn't through scarcity, it's actually through value creation. And I think your organizations like the ones in this room are going to be the ones that actually prove to the market that that's the direction to go.
Great, thanks. And John, we talked about, you see a lot moving in value-based healthcare. And can you talk about that movement and what you see the challenges are and how you're helping your clients move forward?
Sure. I think so I'm a former healthcare exec in various roles. I've run employed physician networks and been a chief medical officer and a CMIO of a large multi-state health system. And now in my consulting role, almost every health system that we work with recently spent $100, $250, $400 million, whatever it is, on deploying an EHR. So a year or two later, the CIO and the CFO are oftentimes scratching their heads saying, what do we get out of this except sort of digitizing our paper chart? And what do you mean I can't generate reports? And what do you mean this tool can't do analytics and all the things we thought we were going to be able to just sort of flip the switch and get out of it? So as we have those difficult conversations and try to help health systems understand that they're going to have to retool internally their own processes, and it will require additional investment in technologies that currently have to be layered on top of your EHR. I think the danger of those conversations is many of the solutions that are out there are really focused on a world that to the primary customer in a health system is still 5 years away, or who knows, maybe it's never going to happen. So they face the challenge of preparing for a climate that they can sort of crystal ball see as in the future, maybe someday, of being reimbursed on a value-based premise, but also struggling with an average of I don't know, maybe 5% margins or something for many health systems, and just keeping afloat and being successful today. So I think the key is, and for this audience, and I'd love some feedback on this, is really focusing on solutions for health systems that can prepare them for that climate that we think is coming. And I'll give you, there are some good examples of where it's present today. But largely, in still a fee-for-service world, how do we take those same technologies and those same internal capabilities that health systems have to develop and be able to leverage them today to improve not just quality, which is near and dear to my heart in particular, but also improve their operations today. And I think there are some, compatibilities with what you have to do to prepare for tomorrow that can make you successful today. So I'll give you an example. So if there's a whole lot of healthcare that exists out there that is appropriate and is just not being delivered to patients. It's needed, it's required, and it's evidence-based. And that care gap out there is, I think, one area that we try to help our clients be able to identify and close. And those, if you think about what it takes to do that, the technologies and the approaches it takes to do that, so take a population of patients you serve, understand what their current state is, compare that to what the opportunities are to deliver the needed care for that individual patient or group of patients, and then close that gap by engaging the patients and the providers and other caregivers that you need to align to deliver that service, and then delivering it. So anyways, that's one sort of example, I think, of how we have to make practical today the solutions that prepare people for tomorrow.
Okay, great. Now, as we talk about, I'm going to open this up to whoever wants to jump ball it. Patient engagement. There's a lot of talk about patient engagement from each of your organizations. I'm sure you have a different focus on what that means and how you engage patients and whether that's a good thing or a bad thing. Does somebody want to take on how your organization is getting into patient engagement?
Yeah, one of the things we're doing differently, we're creating a new store format, which we call a Well Experience store, and we have some here in New York. And with that, the idea is to improve patient engagement for our pharmacists. And what that format does is bring the pharmacist from behind the counter into a desk in front of the counter. So rather than be seen as just a pill distributor and a production house, which, granted we do, that's all being hidden away from the consumer. And make time available so the pharmacists can do consultations. Next door, then there'll be a privacy room so they can do vaccinations and other things that may require more time and engagement. So that, to me, is about the height of engagement. At the same time, with technology, we are investing heavily in patient portals and online information, content search. We're looking at building tools related for people to help manage wellness over time. And at the same time, in the other parts of our store, we're trying to do more patient engagement by the fact of having fresh food. And in some communities across the country, we're the only access point for them to have fresh food, where really it's only fast food that's available that may not be quite as healthy. And all that does is add a lot of cost to the healthcare system. So it's a burden on us whether we realize it or not. So we're trying to do a number of things proactively to prevent healthcare issues by the front of the store, but then through our caregivers, make them more accessible and engage them, and then obviously wrapping technology around it. Our hope is, when you think about where technology can really help, even simple things of send a text, your prescription is ready. But the other idea is for us to, when we get a full suite of vaccinations, we'll send you an automatic reminder that it's time. People say they'll get a vaccination if they know they need to, as opposed to their little yellow book that they may or may not carry and not know. So we could do a convenient, if they opt in, send them for a reminder, they could press a button, schedule the appointment, come in, have their service, get out, and then everything is maintained electronically for them on a going forward basis. So we see our engagement in the store through electronically, and not just one time, but an ongoing over people's lifetime.
Okay, great.
Yeah, at Virtua, we're obviously, as I mentioned earlier, expanding our PHR. We're also expanding our portal. But a lot of those occasions are dealing with patients when they're sick. And so we're also trying now to shift our focus to wellness. We actually run some fitness centers, and we're trying to engage people, all the time, and not just when they're sick.
That's great. Kaveh?
Yeah, we see, no matter where you stand, whether it's government, payer, or provider, that the emphasis on the perception of value at the level of the individual patient consumer is really what's driving the discussion. Am I getting my money's worth? There was a study published about a year ago, done primarily for the life science industry, but the first question they asked, and this was unaided to consumers, was how do you define value in healthcare? And interestingly enough, about 1/3 of the consumers said not outcomes and not cost, and about 1/3 said they don't know, about 20% said cost, and about less than 5% said either outcomes or outcomes plus cost. Now, that doesn't necessarily mean they don't value outcomes, but I think what it really does tell us is that the definition or the perception of value is more complex. And so the concept of engagement goes back to the literature about, you know, patients want care and compassion, and so you start focusing on these other things. One of the things that's interesting, and we see a misunderstanding, particularly the provider side, is this belief that what the patient experience is about hoteling. But actually, I think the research is different. The research says that what people are looking for largely focuses around transparency and self-control. And so the concept of patient engagement, whatever side you come at it, if it embodies those things, then that tends to drive the notion of a good experience, a compassionate experience, and then people start to actually differentiate on value. So they expect outcomes as a minimum. That's the right to participate. Transparency just raises the bar. Nobody competes on that except at the high end. All the actual value differentiation occurs with the other stuff.
Okay, John?
So I've heard some interesting things, and I think one trend that is worrisome to me in the industry, but not surprising, is I think, you know, one of the panelists talked about sort of the, you know, creating these walls and trying to be, Kaveh, it was you know, sort of just protecting the data and the relationship with the patient. And we're certainly seeing that in the patient portal space. So all the major vendors now either have patient portals or they're developing patient portals. And that is becoming a really great way for patients to interact with whomever owns that portal. Unfortunately, it's still not a great solution for the patient to use that as a tool to interact with their assembly of providers. And there's absolutely no incentive right now, particularly for the big EHR vendors, to cooperate in that space. So I think until that changes, that's going to be an ongoing challenge. I don't know if you guys are, people in the audience, probably some of you, I'm sure, are familiar with the PCAST report. And when you talk about that, look at the direction that the government's trying to drive us in terms of true interoperability, it makes the big vendors really nervous. And right now the response has been, we're going to protect our turf as much as we can. So I think that's going to be an ongoing challenge. The other thing I thought was really interesting, Tim, is you know, in the retail space, the rise to prominence of pharmacists, and that's something that we see every day. Pharmacists are becoming more and more important, and I think it's a great example of where technology is freeing up really capable, licensed folks to be able to do what they're trained to do. And we see it in the ambulatory side, certainly, particularly in the retail space, but in the inpatient side, we see it as well. Most of the EHRs, one of the best sort of tangible ROIs you can get is around pharmacy. Your pharmacy department becomes way more efficient, gives you the opportunity to take your pharmacists out of what's usually a basement, you know, office with no windows, and put them up on the floor directly with providers, helping them face to face.
Yeah, just a footnote on the pharmacy piece. Full disclosure here, we're actually doing a deal with Walgreens where we're putting one of their pharmacies in the first floor level of one of our new hospitals, and then also having medications delivered to the bedside as you're, you know, exiting the hospital. So we firmly believe in, you know, partnering with people. Also, this idea of freeing up the data between parties in the community. The sort of motto I use is, you know, compete on a lot of things, but don't compete on information. Because at the end of the day, everyone's really going to truly benefit from that. To that point as well, I think we have to, one of the barriers out there is really around our quote-unquote medical disclosure laws. And so if you look at all the state laws, even in the state of New Jersey, we have different laws that regulate the release of information, whether you're in a physician office, a hospital, a nursing home, or home care. And all that affects how we set up our HIE. So there's a whole bunch of political barriers even before you even look at, you know, just the normal technical, you know, startup issues.
You know, to Al's comment, one of the things, patient discharge is a big opportunity, and one of the things we're piloting, this is where simple technology, I think pretty straightforward, could be very helpful. One of the things we're piloting in this process where someone gets their medications at bedside is that we're just doing collaboration, video conferencing to that patient in their bed with a remote pharmacist. Now, what I'd like to be able to do is make it the pharmacist that's in their community. So then they have that first conversation. Granted, it's virtual, but that's a very strong engagement and value proposition so that they know what's going on. So when they do come home, then that ongoing care has high quality, but is done at a much lower cost. And just using FaceTime or something, so we're looking at different technologies to be able to do it in the right manner, I think is an interesting way where technology can really help provide a higher quality and reduce costs.
Thank you. I mean, that's all very interesting. I think we've had a lot of clients, and there's a lot of new companies over the last 18 months. If you switch to thinking about the entrepreneurs in the audience and outside the audience and what they can do for you guys with the Groupons and the Zyngas and all the froth in the market, we've seen an explosion of companies that develop apps for wellness, apps for tracking this or tracking that, iPad applications to connect with somebody to transmit some sort of information, gaming companies, healthy this, track your run. Have you guys seen these companies come in to see you? How can they be helpful to you? Which of these kinds of new mobile technologies would be useful for you today? And what would you tell people because there's a lot of companies in the audience who have these smaller companies focused on health, wellness, gaming, engagement, couponing, something like that. Tim, maybe you're a natural to start because you have the retail stores.
Well, I would say the first thing that we have a lot of access and opportunities with these, and every day new opportunity. And I think to the comment earlier, it is a very exciting time to be in healthcare. A lot of fabulous solutions are coming to the marketplace. The thing that for us is when someone comes, a lot of people will come up with a niche solution and believe that they will own the data. I could not agree more that the data has to be shared and interoperability. And anyone that comes to the table that says they're going to own the data, I just saw it 2 days ago. Someone said, no, they're going to own the data. I said, we won't talk to them. Because we need to have the data provide good care. And if you're violently opposed to that, well, then you're really not signing up for what we believe is best for the patient at the end of the day. So I would say that in particular. I think the idea that it has to be, mobile and open platforms is obviously critically important. But I also think over time, for us, we're looking at full end-to-end continuum. We're just not looking for an app on the iPhone. We do our own Walk with Walgreens, right? And we did that, launched it with the Celebrity Apprentice show. And on the back of that, we intend to take that, and over time, we'll offer incentives and rewards and so forth. So we're looking at providing that end-to-end continuum on wellness ourselves. But it's really about the technology has to fit into the broader strategy and has to be easy and convenient to use.
Yeah, I get calls literally all day, all week from different companies that want to introduce me to their services and products. And the issue we have is that we have limited dollars. We're a nonprofit. We're buying MRI machines or we're buying other things that we need to buy to replace equipment that dies. And there's only so much bandwidth to invest in what I call R&D, newer products that require, quite frankly, a lot of staff time to work with your staff to make it really work. And so we have to very carefully choose which of those solutions will truly have benefit. Will they last for 3 to 5 to 7 to 10 years, or will we constantly be replacing them? So we just have to. We're very careful in terms of how we do this. I wish we could do more, but there's not that deep pocket to do that.
Kaveh, what do you see?
Yeah, more sellers than buyers. Right now, we're struggling to know the difference between interesting and important. There's only knowing all of your biomedical or all of the functions of your body all the time when you're healthy is interesting, but not worth that much money in a sustainable way. So I think people sort of get preoccupied with what's interesting to them and the assumption that there's a mass market. That being said, there is an expansion of the notion of health care to include health. And so to the extent that there are buyers, if you will, companies that see their mission as enlarging, then they may be potential customers for these sorts of technologies. So I think that is a good place for this conversation, for those people who are innovating like that to go. But I do think that when it's all said and done, the people who are creating these things have to really put this against the challenge of interesting versus important before they go too far. Because I see a lot of ideas that, in my mind, don't meet that test on very first blush.
Sure. Okay.
Yeah, I agree. I think so we work with a number of vendors in the analytics space, and you hear about predictive analytics, and again, it's interesting, but probably not highly valuable in a broad sense today. I think it's part of that future climate and those capabilities that are going to take you 5 years to get good at and figure out it might be worth pursuing. But for the folks who are buying today, particularly from the health system side, the folks who are writing the checks, I think it's really more about descriptive analytics, just using tools that help you understand the population that you serve, be it in a geography or network of patients under a specific insurance umbrella for a large employer, et cetera, and being able to monitor those patients in a way that allows you to capture net new revenues while appropriately delivering the care that those patients need today. So for diabetic, it's great if you have technology that can help you track their progress over time, make sure they're up to date on all their labs and their visits, et cetera, especially if you can use that same tool to, when you identify a care gap, to get them into one of your service centers to be able to provide those services.
Can I just add a follow-on?
Sure.
I think that the 20-year push around information technology and health being about the EMR has caused us to over-calibrate on technologies that focus on clinical data. But the reality of what's going on with affordability is that people need to find ways to change the dynamics of the production cost. And so the technologies that focus on workflow, communication, collaboration, I think are going to have more lift in the future in terms of being valuable to businesses, people who are paying money, than the ones that simply move biological data back and forth. That if I had to bet, I'd bet more toward the processes than I would about the data movement, sort of the interesting biological data movement.
And just a little footnote on the cloud computing piece. Where's this data? Because a lot of the companies are storing their data in the cloud, and the issue that we have is really the security of that data. You all read the big stories about the breaches that happen out there, and the cost, and that really comes back to us. So Gartner came out with a study about a year ago that said, who's not investing in cloud services or buying cloud services? It's healthcare providers. It's the financial services industry, and it's military contractors, because we're under such regulatory pressure. So not that you can't do cloud storage, but just really have your story down and how you're protecting it, the data there.
Okay.
That's why we're going private cloud, not public cloud.
Right, and we're all private cloud.
Yeah.
So I'd love to go back to the cost side. I think that's a great point, Kaveh. So there are people writing checks right now, payers and employers in particular, and maybe they're the same, who really care about the cost equation. And health systems, the providers themselves really care about the cost side. I'd be interested to see in the room today, of all the technologies that you either own or you represent or invested in, how many have tools in their portfolio that really help all the key stakeholders understand where their costs are in the care delivery system? There's not a whole lot, right? So I think people talk about being able to do activity-based cost accounting, understanding at a really detailed level, fractionally, where the costs are in your care process. That's incredibly difficult to do, and there's a huge gap in the technologies that can support that.
Thank you. One of the big areas, obviously, government for the last few years is now funding a lot of this technology. And one of the big debates in the investor community, small companies, is are they funding it to a good outcome or a bad outcome? Is the money being well spent? So we've had meaningful use 1, billions of dollars being poured in. Meaningful use 2 is coming down. As the provider group, how are you guys reacting to get your hands on the money? Do you feel like I know there's government folks, and I'm sure all the money is coming in and it's being well spent and for good things, but is it contorting you into different areas, or has it been helpful to you in going to areas you were going to go to anyway?
From a Walgreens perspective, I've been somewhat vocal that I think we could have done this much better as far as interoperability. I think, and especially in financial services, this has been done from the standpoint of member-owned, member-governed. Government didn't have to pay a dime. The industry came together and solved interoperability by itself because it was in their best interest to be able to do it. And I think the government could have been a catalyst for it, but I also don't think government could actually solve it. Yesterday, I think I was at the University of Chicago Booth School, and there was a quote from Milton Friedman that said something like, government getting involved in the problem could be bigger than the problem itself. And but at the same time, I think the intention is right. I mean, you try to bring encouragement because what has held back healthcare IT before, arguably maybe attorneys and all the fears of HIPAA compliance and mistakes and errors and lawsuits. So I understand that. So I applaud the government for its intent. I do think they should have provided a better system for interoperability. And that system, to me, when you look at interoperability and just exchange of data and is being pursued by for-profit, I just don't think that works. I think a common utility that lays out a physical network, highly secure, coupled with message format types for the different things that we want to exchange around continuity of care, referrals, payments. I think you could have gotten a collection of hospitals, payers, pharmacies, whatever, of people who would have come together and worked together for the benefit of the industry to come together. It would have been cheaper for everybody, by far. It would be, I think, higher quality. So it would be lower cost, high quality care, rinse, repeat, rinse, repeat, rinse, repeat, and you do it millions and millions of times a day. Now, I would also say this exchange would only be an exchange. It wouldn't house and store anything. Now, some people say, well, there are entities out there that can do that. There are some trying to do it, but there really isn't one entity that could do it. So for us, the contortion for us is we're in 8,000, we're in communities across the country. The HIEs by nature are regional. So for us to hook up to 250 plus different HIEs is not an easy task. Sure. So for us, we have to find our way through it, and a common way to do that across the nation, I think, would have been better. But everyone says, well, it is what it is. So the way we're going and working with the Direct Project and other things, I mean, we're enthusiastic and supportive of it. Could there be a better way? Yes. But at the same time, it is what it is. So we're doing the best we can to work with hospital systems and others, technology, software providers, EMRs, to do anything we can to try to bring as much common low-cost exchange of data across the country.
Yeah, I think, the High-Tech Act, which is really, I think, what you're referring to, Brad, was really a jump start for those who were not early adopters. There were lots of healthcare providers who were early adopters of EMRs, even to get on the information highway. And the dollars that you hear about really are just going to two groups, literally, acute care hospitals and physicians in their offices. Now, the other layer on top of that, what Tim's referring to, is really that interoperability layer. So they tacked on certain requirements for interoperability, and the stage 2 for meaningful use has a lot more of that. And Tim addressed it well, is that they've attempted to do some standards, and they've been published in the HITSB group and so forth in Washington. But it's still amounted to basically 250 HIEs across the country. 3/4 of them are private, quote-unquote, HIEs. So there's still a lot of work to do to get all that to work together. But I think we're in a better spot today. We almost wouldn't be having this conversation had not in 2009 some of these money's been thrown in there to get people to a new level playing field and actually a common vocabulary around this topic.
I'll add a comment. I think meaningful use has been great to sort of kickstart people, as you say, and it's created a whole sector in my company of optimization to help people once they've rushed to just throw something in to actually try to make it work. So it's been good for us too. But I think that is one of the drawbacks. Clearly, people have rushed into expensive solutions that they haven't been able to think through fully. I think that's going to get worse as over the next basically 12 months, if folks haven't implemented, they're going to not yet hit penalties, but lose the first chunk of money in the sort of narrowing down of funds that are available from the federal government. So about a third of the money is going to evaporate if they haven't implemented over the next year. The second thing, though, I think is important, and when we talk about the High-Tech Act, that there's a piece of it that people often forget, which is CMMI, so the Innovation Center. And this is probably near and dear to the hearts of you folks in particular. There's $1 billion out there for innovation grant funding, and the first round of the largest chunk of that money is already sort of in process of being evaluated. I suspect today, this afternoon, CMS is about to make an announcement. I think it's going to be that there will indeed be a round 2. It's a great opportunity to take technologies that you guys either own or represent, partner with a health system, particularly if you can partner with an academic health system, and get some government funding to implement these tools and solutions in the real world and prove that they work.
We're going to want to open it to questions in a few minutes, but I'd like the panel to address ACOs, health home ACOs. Different folks are calling it different things. Is this going to have legs? Do you see them being put to work in positive ways? What are your predictions about where the ACO movement is going to go? Kaveh?
Sure. I think it's a reasonable experiment that's actually part of a much larger transformation. So I don't particularly worry about whether or not the specifics of an ACO program are durable as much as the real, we're clearly in a migration from payment for activity to some kind of payment for value. The intermediate phase is actually budget-based payment. It's not the destination. ACOs are a budget-based payment model. They're not the end point, and we'll figure out as we move through it. I have mixed feelings about the concept of aggregating risk at the level of the delivery system, because historically, if you actually think about fundamentals of insurance, you are supposed to aggregate risk in a random fashion. It raises interesting questions about whether or not one could consistently aggregate risk at providers, because at some level they're inherently not random in the way that they organize and attract patients. But that being said, people assume that there's financing mechanisms and risk adjusters and stuff that can solve for that. What we do see is the following, though, which is that it is forcing, appropriately, the delivery system to get their arms around capabilities that are typically found only on the financing side of healthcare. Understanding budgets, understanding parties not themselves, and how the economics work. That's all a good thing. So my view is that it's a stimulus to an experimentation, kind of like high tech, that will get a bunch of capabilities put in place that will ultimately be useful.
Great.
Yeah, I agree. I think this is a direct quote from a CFO of one of the top 20 health systems in the country, who's part of one of the group of 34, whatever there is total between the pioneers and the add-on ACOs, which is, I don't know who got us into this, and I wish I could get out of it. So I think in today's world, even for the folks who have sort of volunteered to be sort of the early guinea pigs with this, there's still this huge trepidation because, first of all, most of their payers are still fee-for-service, and if they say, okay, I can get a 1% bump or whatever it is from my CMS patients, that does nothing for the huge majority of my patients that I'm getting Medicare plus 15 or plus 20% or whatever it is, and those are the folks I really have to concentrate on. So I think you're right. It's a great idea. It's a great intermediary step to get us to where we need to be eventually. In the here and now, though, I think it's going to have trouble finding traction.
Okay. Al, did you want to take
that? Well, it's a means to an end, and I think it's back to the future somewhat. We're seeing some basic concepts like capitation and bundled payments as being part of that intermediate step that's kind of budgeted. But the train left the station, even if the Supreme Court overturns the Accountable Care Act. I think there's still market pressures, as I mentioned earlier, from basically us taxpayers that pay for health care through the federal programs. Also as consumers that buy goods and services that ultimately our employers pay premiums for things. So there's pressure there to do this. And luckily now technology is there, as I start off, as an enabler to make sort of that happen, as long as the other barriers come down around sharing data and all the consent laws and the archaic medical record release laws. As long as all those get fixed as well, then I think we're heading in a good direction.
Last question before we open it up to the audience, and this is, given there's a lot of young companies in the audience, given there's a lot of investors who invest in young companies in the audience, John and Kaveh, you talk to buyers all the time. Tim, and Al, you guys are buyers. You mentioned earlier today, people call you every day, multiple times a day. What phone calls do you take? What attributes does a vendor need to have? What solutions? Is it ROI? Is it, they give you a coupon to go to Walmart or something? Or which of those calls do you take?
I don't do that one.
Which calls do you take, and where should investors be putting their money, and where should the entrepreneurs be spending their time to get your attention? What holes do you have that need filling, and how do they grab you?
Well, I'm typically listening early for what is the essential intellectual property. People who begin with a lecture about healthcare problems aren't. Then you see a lot of presentations where it's not really clear what the IP is, as much as it's a sort of some attempt to try to do some things that people have maybe done in a different way. So I'm interested in where there's IP. I'm actually pretty interested in trying to calibrate quickly as to whether they're trying to solve the problem that's going to predominantly be registered as a reduction in cost versus a change in patient quality. Not that they're bad, but it gives me a quick sense as to markets. And the third is there's a clarity around who the buyer is and a business model. Because many times these organizations have some vagueness in the perception of who's going to buy. And that's if you don't build it with the clarity of who's at least first order buyer, it becomes a problem. Those would be three things.
Great.
Yeah, not much to add. Again, I think finding solutions that can help people continue to generate net new revenues today while delivering their care and following the mission, particularly if they're on the provider side, that they're built for, to me is the key.
I think in my case, first I ask that company to listen to what our needs are so they understand our plan. And I'll tell companies, it sounds interesting, but you know what? I bought something like that 3 years ago. We got it covered, sorry. So that's the first thing is, do we have a need? Secondly, have you spoken with other companies, other large IT companies in the healthcare space that you're ultimately going to have to integrate with? So in our case, we use Siemens Corporation, NextGen, a few other big vendors, and some of them say, I don't even know who they are. And the third is simply, what kind of backing does the company have? Are you going to be here in 2 years, 3 years, 4 years? So basics like that.
I think for us, it's, for me, phone calls and emails really won't work because there's pretty strong firewalls. We just don't have time to talk to all of them. So the reality is we have people that are active in all the outreach in the communities, looking and seeking. So there's far more ideas than we have needs. But the first thing is, does it fit into our strategy? If the answer is no, we'd move away from it. Will it be able to scale to our size that we would need through our system, the organization and or the technology? And we always look at both. So that's fundamentally important. And then do they have the right mindset of shared strategy of is there a good cultural fit? And if we could get through those three, then usually we move pretty quickly through the next phases.
Great. Thank you. I'd like to open it to the audience for questions.
So the question is for Al. So we provide mobile technology, primarily medical device connectivity applications, and we were able to demonstrate ROI from the ambulance to the hospital and now looking at home monitoring. Hopefully you heard the past, whatever I said. So what is happening to us in 2011 is that all of a sudden large organizations like HCA, Texas Health, Dignity Health, CHW, they came to us, we were able to demonstrate the value, and now they are even investing in the company. The issue that we have is we're starting to get a lot of phone calls from providers, but not all of them have the right vision. So the question to you is, not everybody realizes the importance of how they can bring technology to make an impact on chronic disease management. So sometimes it's harder to educate that audience as you start bringing the technology. So the question to you is, which calls do we take? Which organization do we align with in order to start bringing this type of technology?
It's a good question. I think one thing you could do is go out and look at, go to the governmental quality sites and check the quality indicators and metrics of different companies, even begin to see where you think they have opportunity for quality improvement. And that's, so at least you're walking in the door saying, I tend to see your results as X. Here's how we can help you. And then maybe you get your foot in the door on that. The other basic piece is, we have to have the people to respond to that. I have to have a cardiologist who's willing to work with that. I have to have a group of nurses that's willing to follow up on that data that they're reading off of that probably portal that you have where the information is published. And right now I've got nurses doing other things, and we're not quite ready for that yet. We just don't have enough horses to look at that information.
Any other questions?
What are you seeing in terms of consumer adoption of the portals and other ways that you reach out through technology to the patient base?
So the question is, what are the panelists seeing in terms of consumer adoption of the portals and your efforts to reach out?
For us, we see a significant pharmacy refill. Our scan app is growing unbelievably. So the convenience of taking your iPhone, scanning your bottle in 12 seconds has brought tremendous. And then the other things we're doing, we built an app for the reminders so people can manage their medications throughout the day. I would say as much as the patient themselves need it, but we're really seeing a massive interest in people around them. Maybe a son or daughter or something is also to assist, because if they're able to get insights on how their parent is doing remotely, so those types of technologies related to consumers is really picking up. Some of the things around fitness and so forth, there's more of an interest, the Fitbits and the other types of things. So people are taking a more active interest as they get educated. So I'd say we're still in the second inning, but I do think that clearly people are looking for these types of solutions and being able. I agree with the idea that you don't want to know everything that's going on every day, but I do think technology can be passive in the background. So one of the things we're doing a pilot for is looking at, blood tests for diabetics, and then it automatically uploads to our cloud. Well, the nice thing about that is rather than wait for the next 90 days to go see your physician, we can do we're doing some analytics around it. This is the hope. We're not doing it today. But the idea is then you might see something and intervene, and then you can contact that person and say, now is the time you need to go. So that way it's more of a quality-based as opposed to a timeline-based intervention. And I think those types of things, as we start to see those improvements in the ease of use around it, I think those passive types of things could be very, very helpful to patients themselves, to doctors, and healthcare in general.
Kaveh?
Consumer technologies that have a social aspect, consumer technology that have a self-service aspect are the ones that seem to be getting a lot more interest than the traditional sort of curated authority, just telling people what to do. And then ones that have true transparency. So, for example, on the health plan side, ability to actually know what your out-of-pocket costs are tend to attract attention because that's really what they're interested in. They trust the health plan as a legitimate stakeholder in terms of communicating what the costs would be. So I'd say those three things.
I'll just add one comment from the EHR perspective. EHR portals, some of the best organizations that have very active programs to engage their patients. They've got doctors and nurses on the front line talking to every single patient that walks through the door saying, here's your code, sign up, use our portal. They've got television ads. Kaiser's a great example. Group Health Seattle is a great example. They can get up to 80% of their patients onto their portal. I think a more typical example that we see for folks who have an Epic or Cerner, they can get probably about 30% of their patients today. But it all comes down to value, I think, and transparency. The Open Notes project, I don't know if you guys are familiar with Open Notes. So it's taking provider notes and making the actual notes available to the patients. Sounds scary to everybody, when you first start, but a year later they went and looked back, and even the providers who were in said over 90% of them said, this is a great thing, let's continue to do it.
Okay. Probably one more question. David?
Yeah, thanks. This has actually been an extraordinarily informative panel. One of the interesting remarks was made early on with regard to relatively large expenditures for EMRs, the financial benefit of which is to be seen. But there is, in the Accountable Care Act, and whether the Act itself survives or not, I believe this part will survive, and that is the government's reluctance to pay institutions for patients that are readmitted within a certain period of time, where apparently technology can or will play a major role in the management of intaking patients, treating, and the discharge piece. And various of you have referred to this. But I just wondered if you had any further comment on it, because it comes with financial penalties that are actually quite calculatable up front if you don't meet certain thresholds. So just your comments in that area.
We have 51 seconds for Kaveh.
Well, I mean, certainly some amount of readmissions are preventable. That's been known. The argument as to whether or not one needed an electronic medical record or one needed to simply change other aspects of the way care was delivered, I think it doesn't really matter, right? The economic argument that's sitting underneath that is if you could do something to prevent it, do it. We'll calibrate correctly. I'm not sure the program is designed version 1 to be correct, but I think that there's a lot of, at best, the clinical record is informative to the care providers, but the issues necessary to actually prevent that readmission probably are a lot about a lot of other kinds of decisions, including communication and understanding of the patient as to what exactly is being told to them, that have essentially nothing to do with the electronic medical record per se.
John?
2 seconds. The last thing, there's a whole lot of solutions out there to reduce readmissions. I think the ones you're going to see that are effective are not just technologies, but have a service component attached very closely to them.
Okay, great.
Great.
Thank you to the panel. Thanks, everybody.